gap. And then I'll in the second part, I'll be speaking about colonization of global health. And finally, I'll be speaking what will it take to decolonize global health. I think that's the last part, right? It's 3 parts. And I had in mind, very much in mind, this group of professionals in the area of health, medical and otherwise, and what would be practical, what would be something not only practical, stimulating, and that would bring on a discussion on your part. So I'm expecting you to participate, okay? Can we move then to the brief view of global health? So global health, it often entails partnerships between institutions in low and middle income countries. This is a good definition instead of using the older terminology of third world countries, developed countries, underdeveloped, in the process of development. So we speak about low and middle income countries to refer to the centrality of the question of economy in that sense, that were previously colonized, and high income countries that were colonizers. So we start off with a relationship of power, with a relationship of that is characteristically asymmetric. Can we move on? Little attention has been paid to the legacy of former colonial relationships and the influence they have on global health initiatives. We understand that a good majority of the countries worldwide are no more, and this is something that we should be very working towards concluding that, but a good majority of the countries in the world are not anymore in the colonial framework. They're not colonized. There are exceptions. There is the Palestinian situation, there is the Western Sahara situation, colonization, and there is Kashmir, and a couple of other, around 17 countries altogether, according to the United Nations, that are still non-autonomous and that still need to have their autonomy. Can we move on? So the feeling many times is that colonialism has ended, but we have new terminology. We have something called neocolonialism, which is the manifestations, the current manifestations of that legacy, of that history. And at the same time, what we have is models and paradigms, ways of thinking and acting and decision-making that influence until today, even with the passage of 30, 40, 50, in the case of Brazil, 200 years, we still talk about colonialidade or coloniality. But medicine in particular had a very, very important role in colonialism, and it cannot be ignored. It requires critical review, namely the biomedical model, which is predominant. I'll explain why the biomedical model in specific has that colonial legacy and how it impacts until today in many countries and societies. Next, please. Additionally, there is asymmetry that characterizes research partnerships between benefit and that often benefit the better resourced partners. So when we speak about global health, there is interaction, there is exchange, there is movement from one place, typically from the higher income countries to the lower income countries, and to the middle income countries also. There is this classification according to the United Nations. This movement is asymmetrical, and what are the repercussions? Can we move? So as I was saying, it entails partnerships between institutions. Oh, we didn't move, did we? Oh, right, yes, the very last point. Inequitable power dynamics and neocolonialist assumptions continue to dominate. Next, please. Colonialism directly impacted medical practice and education in Africa. When we speak about medical practice, we're really speaking about everything. So nursing, dentistry, all the different, the paramedical, if you like, in the States, this is what they call them, but all different kinds of professions that also encompass the practice of medical care. So medical practice and education in Africa, by using medicine as a tool for domination and control. So it wasn't an innocent thing, and it wasn't purely humanistic. Let's see how. Medicine provided a biological rationale for assigning racial superiority and or inferiority. I'm sure many of you are aware of the studies, the racialized studies that were said to be scientific and that would measure the skull, the body of populations and communities in Africa and Latin America and accord to them in comparison to the European white inferiority based on that. Thus, medicine was used to rationalize and justify inequalities and excesses under imperial domination. I'm sure many of you are aware of the fact that the Pope recently, if I'm not mistaken, last year, apologized formally to the indigenous Latin American populations for the crimes that the church had effected on these populations. We know that the church had and still has a lot of association with medical care and medical practices. The philanthropic hospitals, for example, are very well known, and we know that much of the time there was focus, or during certain periods there was exclusive focus on moral issues from a Christian perspective, and that basically essentially dominated the societies and the communities and the countries where they operated, be it in Latin America, in the Middle East, and in Asia and Africa. Next, please. Such rationalization is heard in the proclamation by French colonial strategist Herbert Lyautey, I hope I got him right. And when he said that the only excuse for colonization is medicine, the physician, if he, okay, or she, understands his role, is the most effective of our agents of penetration and pacification. So let's see what these two key words mean. Can we move? Thank you. This penetration and pacification manifested in various ways. So tropical medicine, and I'm sure many of you know about the famous London School of Hygiene and Tropical Medicine. I did a training there in medical anthropology, but we have others as well in different Instituto Pasteur. It appears to me also has this inclination in Portugal and in many parts of Europe. They would have these institutes, medical institutes with focus on tropical medicine. As it was called in colonial times, was used to control and restrict the movement of indigenous peoples, such as through quarantine measures of local populations designed to prevent the spread of human and livestock infections. We know for sure now that the models of urbanization caused by the introduction of capitalist modes of production and the overuse and robbery, actually, looting of resources and mining, both in Africa, in Asia. If you think about the rubber industry and many others, practices that were intended to loot these countries effectively, to rob them of basic resources, were causes direct causes for widespread diseases. This, in addition to the introduction of diseases from the Europeans into the indigenous communities. So it's not as if they arrived to the communities, the Europeans, the colonizers, and found these communities and societies with widespread diseases. We must understand it from the perspective of the economic and political systems that they introduced and that eventually, with the years, over decades, caused a deterioration in the health of the communities. Can we move to the next, please? Because colonized countries played an important role in sustaining colonial economies, like I was saying, I called it looting, and this is effectively what it was, robbing. Colonizers were keen to prevent disruptions due to disease outbreaks. So there was an economic interest there as well. Medicine was critical for maintaining the health not only of colonial troops and administrators, but also of the enslaved local workforce needed to build colonial infrastructures. We don't say slave, we say enslaved, because inherently the person is not a slave. Nobody is a slave. They are enslaved with the act of domination and power exercised over them. Can we move, please? Colonizers also promoted medical research for the purpose of understanding the diseases that ravaged and disseminated colonial troops at higher rates compared with indigenous populations. We can see this as far as, I know somebody here is from Egypt, but at the times of Napoleon, this is what happened with the army, the Napoleon army, the French army, when they were in Egypt, and they were devastated by several diseases that the local population, the indigenous, not local, the indigenous populations did not have. Understanding the biological correlates of these mortality differences was a path to retaining power over the colonies. Other research exploited effective local remedies such as quinine, I think, from the bark of the cinchona tree, which French chemists tried to purify. We have this, we know about this until today, yeah, the pharmaceutical industry and how they go to the local communities and effectively rub, once again, the knowledge of the communities in regards to the essential components of drugs and medications. South Americans had known for centuries that quinine was an effective medicine for fighting fevers, and it became essential for treating malaria and other infectious fevers in African colonies, thereby helping colonial troops survive. We never hear about this, yeah? We don't know that the indigenous already had this knowledge. We know that the pharmaceutical companies put them in small boxes, and that's what becomes a patent, right? A scientific patent, a discovery, and so on. Can we move? Thank you. Colonizers also, no, I'm sorry. Okay, research on tropical diseases was also critical for understanding epidemics. Cholera, which for example, ravaged Europe, that were thought to derive from unhygienic slums in the colonies. Next. So this was really rapid. I would like that if anybody of you has a contribution or ideas or questions in regard to this very brief, and I made the point to say that it's a brief contextualization, if you like, in regards to global health, whereby it concerns not only the economic and political interests, but also what it implied, what it left, the legacy it left for the population in terms of medical training and medical practice. So when we speak about the can we go back so that people don't read it? We go little by little. Thank you. Colonization of global health. It refers basically, in very, very simplistic terms, refers to the idea that Western researchers and health practitioners, the two are important, not just the research, the practitioners impose decisions and solutions on poorly resourced countries without involving people from those places. And this definition, with its simplicity, is extremely important because it's very precise, because it does not oppose to the idea of collaboration, but it says that there is something wrong with this, with the nature of implementing global health. And that's why it's called colonized global health. Can we move, please? So we're very close to COVID pandemic, and it has shown us so clearly that decisions of who gets access to drugs or to vaccines did not include the poorly resourced countries. Next. In April 2020, the WHO General Director, he had to clearly state and oppose the idea of scientists from Western countries who were proposing that Africa serve as a testing ground for vaccines. This is yet another dimension of colonization, the lack of ethical practice. And he said, the hangover from a colonial mentality has to stop. This is 2020, we're not talking about last century. Next, please. Solutions originated in the West had failed to take into consideration the reality of millions of people, such as social distancing. So if you remember at the start of the pandemic, there was huge emphasis, while the vaccines were not liberated and were not accessible, on social distancing and access to water, 2 dimensions or 2 conditions or 2 recommendations that are not easily accessible for a good part of the world, we can say, but for millions and millions of people. So this is important. What science is made, how the recommendations are based. Are there other solutions? Could there have been other solutions taking into consideration the reality of these millions of people who cannot afford to do the social distancing? For example, in Brazil, this was very, very clear in class terms. So the poorer population could not afford to stay at home for a week. They had to work because they gained their money, they gained their income on a daily basis. So they had to expose themselves to dangerous and effectively deadly results. In Brazil, we have about 700 million or 800 million people, 1,000 people who died unnecessarily because, and in part, in good part, because of the exposure to situations like that. So the economic factor, poverty, and the lack of other options were extremely important. Whereas in European countries, we know about that, there were social benefits that were liberated or that were made available for people so as to stay at home and to maintain social distancing. I hope it is clear for you the meaning behind that and the question of access to water, of course. And we know that there's a huge pollution of much of the water all over the world. There's a crisis. We know also that it's not just from now, for many, many years, the question of safe drinking water has become mercantilized at the expense of bottled waters, and companies like Nestle that are that have got huge in the billions returns from this process of bottling the water and not making it accessible in the way that it would be and could be. Next, please. So colonization of global health is also images, is also symbolic, deep-rooted reflections of, can you press please, can you click, of the persisting legacy of the white man or woman savior. All of you must be aware of this, familiar with this. You must have grown up with this. We're not talking, mind you, we are not talking, and it's very important to make this very clear, we're not talking about the color of the skin, the complexion. We're talking about power relations, because we can go beyond that. We have many societies and many communities who have fairer complexion and who are white effectively, but we're talking about the power relations, how that symbolically plays. So these are recent images from the work of Médecins Sans Frontières, Doctors Without Borders, that have been criticized internally, by a petition of 1,000 workers speaking about some points that I will address. But I wanted you to look closely at these pictures and to note how the power relation is so clear and is so strong, not only in terms of who is helping who, and that is big, that is in itself is significant, but in the expression on the people's faces and what it means. Can you move, please? Next. Click another one, please. So the colonization of global health, in addition to the persisting white man, white woman savior image, there's the passive image of poor resource communities. You always see these people totally destituted and totally lacking of any dignity. And dignity is a social determinant of health. It should be added, it's a must. Dignity means that people have to be dignified in their condition and not portrayed in a totally destitute, passive condition. You cannot see anything in these people apart from this image that is portrayed. You don't know, this person might be a painter, this person might be an excellent cook. This older man could very well be a traditional healer, and so on and so forth. When you put them in an image like that, they are nothing. They are zero. They are just people waiting in destitution, in poverty, waiting for the saving of by someone. And this is a very, 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 very powerful message. Can you move, please? Click. And the colonization of global health means something even further, and it's more potent. No reference to local traditional knowledge, which is rich in such communities, as if they are destitute of any form of care practices. So who's giving the lesson? Who's looking desperately as if they are little kids in a kindergarten, but they're grown-ups. They're grown-ups, and they're portrayed as if they don't know anything, and somebody is waving at them, instructing them, and telling them what to do. This kind of symbolic relation is extremely strong because it passes on to the little children, and it makes them assume and understand that this is how the power relations are. All these pictures are recent, now, last year, the year before. So we're not talking about history, we're talking about current times. Can you move, please? So what will it take to decolonize global health? I found some interesting references, and I tailored them exactly for you. I mean, this group that is focused on who are currently professionals or future professionals in the area of health. The first thing is to come to terms with key barriers. What are the key barriers to decolonize global health? First, institutional racism. This terminology is referent to that petition I told you about, 1,000 workers in Doctors Without Borders signed the year before this petition, in which they say that Doctors Without Borders, Children, Save the Children, and others have within them institutional racism of many international organizations that work at the forefront of global health. Because global health, one thing is having it on the planning, in political fora, right? In discussions and meetings at the level of, but it's the most important is in practice, when you do it at the forefront, the frontline workers. So insider staff, like I was saying, they published on this matter, and this is what they said. They said there was a lack of diverse staff at the headquarters. Yeah, local staff often have no decision-making powers. So European or members from European countries are the ones who are in the headquarters. European, Western, not just European, American, Canadian, Australian, and so on. And so the local staff have no decision-making powers. Next. And these organizations are not inclusive or sensitive to the reality of poor resource countries, communities. And so you can imagine there is a scenario whereby 1,000, this is one petition that I saw, but there are several others apparently all over, that are questioning the dynamics, the way that it is done, and that this is how the colonization of global health continues. So one way is to come to terms with the fact that there is institutional racism. Next, please. And decolonizing global health education. So this is the second point. I'm going to address in the first place what I've just mentioned just now, the institutional racism. And the second thing is the global health education. And I found this research, this paper, and based on a wide research, looks at it and proposes rethinking institutional partnerships and approaches. So to shift established practices in global health partnerships, these ideas must permeate curricula and influence the thinking of those responsible for curricular innovation. So what is this saying? You train in universities and colleges health professionals. If you train them, and this is done most of the time, alongside the colonial model for global health, what you will find in the international organizations or in the labor market or in the UN, wherever, are people who reflect this curriculum training that they got. So go to the source, go to where you train these professionals, and work on making these changes. So there are 5 recommendations that Eichbaum and something like maybe around 7 authors of this paper. I have the references at the very end, so you can consult them. So this is what they say. They present 5 recommendations. Next, please. First of all, decolonizing by emphasizing patient safety. Next. Decolonizing by applying fair trade principles to educational programs. I'll go in detail on each one of them. Decolonizing by developing global health curricula, learning objectives and competencies. Yes. Next. And decolonizing by addressing power dynamics and development narratives. The last one. Number 5 is decolonizing by equalizing access and opportunity of educational experiences. So I'll go through them one by one. Am I okay on time, Louisa? Okay. Next, please. So what does it mean, decolonizing by emphasizing patient safety? It means to address activities that may affect patient safety. The University of Minnesota, this is one example. In the paper, you will find others, but this one I thought was interesting, has created global ambassadors for patient safety, an open access modular online platform. Let's see, what do they do? Next. The GAPS tool serves several functions. It prepares students for ethical issues they may encounter abroad, emphasizes the risk to patient safety of inexpert or culturally and linguistically incongruent care provision, and mitigates moral distress by allowing students to decline, to not accept, to do things beyond their scope of training. Because apparently this happens. It culminates in an oath available in 7 languages that students sign, committing to be ambassadors for patient safety. Next. This initiative is decolonizing in that it takes seriously, in terms of ethics, equity, and appropriate medical expertise, the safety of patients in lower and middle income countries. Next. Decolonizing, number 2, decolonizing by applying fair trade principles to educational programs. So what does that mean? Fair trade learning is a movement led by Global SL, an organization focused on partnership, mutual learning, transparency, and sustainability to engage the global civil society in educational exchanges toward fostering a more just and equitable world. Next, please. Its fair trade learning rubric is designed to tangibly and intentionally move, i.e. to decolonize, global partnerships with power differentials along indicators of engagement from an entry level toward an aspirational ideal of equity and balance, power and privilege. Next. The indicators include common purpose, rights of the vulnerable host community participation, rights of the vulnerable, host community participation, recruitment, publications, and communication. You can imagine how encompassing, broad that is. So from caring, knowledge, participation, and publication, ethics has to go through, has to be something that surpasses all of this. Next, please. Decolonizing by developing global health curricula, learning objectives, and competencies. Yes. The Consortium of Universities for Global Health Competencies Toolkit aim to define appropriate roles and competencies for trainees and professionals working toward health equity and understanding of other cultures and contexts. So this consortium competencies were devised with input from lower and middle income countries. So there was input, this is important, this is key, to guide higher income country trainees and professionals in navigating complex situations when they are in lower and middle income countries with humility, cultural sensitivity, rather than reflexively defaulting to what may be higher income country colonialist approaches and attitudes, or basically saying, I know the answer, I don't need to consult the community, and I have the knowledge. Next, please. So decolonizing is also by addressing, takes place of global health, by addressing power dynamics and development narratives. The asset-based community development approach to community-based development intentionally counteracts deficit-oriented mentalities that reinforce colonial power dynamics. Such a mentality impels the higher income community outsider to be impelled by development narratives whose storylines focus on the deficits of resource-limited settings rather than their implicit strengths and assets. This point is key because so many times I heard people working in development agencies, there's nothing there. You go there and it's horrible, there's nothing. It's really, we work in dire conditions and situations, and you don't stop to consult the communities, how did they survive thousands and thousands of years? What kind of resources did they use? What kind of language that I'm unable to capture, to understand? What kind of processes of healthcare or caring for your well-being is done by the community? Next, please. By such narratives, the outsider is presumed to be knowledgeable and capable compared with local communities, which are considered incapable and needy. So the ABCD aims, I like this acronym, aims to counteract this dynamic and ensure greater equity between the less resourced and more resourced and powerful, hence, stakeholders. Next, please. Decolonizing by equalizing access and opportunity of educational experiences. This one I thought was really nice. Next, please. And I think relevant to you, the work that you do. Whereby directional exchanges exist, it is well known that higher income countries' learners traveling to lower and middle income countries consistently outnumber lower and middle income country learners traveling to the higher income countries. One explanation for this imbalance is that higher income countries' institutions assume their students are always helping in under-resourced settings. Yet, on the contrary, visiting higher income country students often place a burden on already stretched healthcare and medical education systems in lower and middle income countries. So we're talking about narrative here, but we're talking about access also and educational experiences concretely. Next, please. And then when lower and middle income country students visit higher income institutions, they frequently do not receive the level of attention that higher income country students tend to receive from their lower and middle income countries hosts. I know this for sure. A student of mine, a medical, now he's a specialist, he's a gynecologist, but he studied with me when he was 18, and he wanted very much to work with students or children with the specter of autism. And he was denied, he went to a European country, and he was denied any kind of access of contact with the children because of rigorous rules and regulations and all of that. But there was no comprehension or no consideration to the fact he was, I think, a 6th year medical student at the time, brilliant, speaks very well the language and all of that. So there are concrete barriers. It's not the same. It doesn't apply the other way around. We don't see this when it comes to lower and middle income countries. Next, please. Decolonizing by equalizing access and opportunity of educational opportunity or experiences. This is the continuation of the last point. Next, please. Some noteworthy model bi-directional exchange programs exist and more are emerging. For example, the International Federation of Medical Student Associations has sustained a bi-directional exchange program since the 50s. Next. That's a long time back. Through student-led organizations like yours in 127 countries, I don't know if you know them, over 15,000 exchanges take place annually using a structure where each outgoing student pays in their local currency for the cost of an incoming student, and that student's cost of living, because we have the financial matter as well as a barrier. Next, please. Okay, so I presented the 5 recommendations, 5 points that this author and this group of researchers have looked into, and I hope that they were useful to you in the condition that you work in this group as well. And so I will conclude my remarks with the following. If global health is to be based on principles of equity, and I saw that equity is a principle that is important to you as a working group, we must confront the historical legacies of colonialism that continue to perpetuate imbalanced power dynamics and inform attitudes and perspectives in our global health partnerships and educational programs. Next, please. We need to address our collective ignorance of these legacies and their impacts on our behaviors and educational practices. I make a point, can we go back? I make a point to say that these beliefs, this collective ignorance, does not only apply in the high-income countries. It dissipates into the lower and middle-income countries. So the population of these, populations of these countries also carry this kind of belief. So we need to get rid of it. The continuing growth in global health education necessitates fresh evaluation of their power dynamics. Power is at the center of all this discussion in regards to decolonizing global health. Next, please. So I consulted many other references to prepare myself, but these are the key ones and the ones that I refer to and I quote in this presentation. So this is the paper I was referring to, Decolonizing Global Health Education, Rethinking Institutional Partnerships and Approaches. It's very recent, 2021, March. And then I consulted several clips, video clips, but these 2 I thought were very relevant. What will it take to decolonize global health? Very recent as well. All of them are from last year. And what does the colonization of global health mean to you? Why is it important today? So I conclude my presentation and I leave it up to Louisa and you, the group as a whole. I don't know who's running the show, but I prepared myself for a discussion with you and some interaction. Thank you very much.
Thank you very much. Okay. Thank you very much, Dr. Muna. Your presentation was amazing, and all the interaction and the references were also amazing, and also the practical things like where we should look at when we talk about decolonizing global health. It was awesome. So right now, what we are going to do is we are going to choose 5 questions for you guys. So please, if you have questions, you can have 2 options. Neither you can put in the chat box, or you can open your microphone, that is also possible, and try to direct the question to Dr. Muna, and she will answer. So please interact, please have questions, so we can have more fluid studies group, not only a presentation studies group. So please have questions, and every question is valuable. So, okay, I'm going to wait for a couple of seconds. Okay, so we have some hand raised. That's amazing. The first one, okay, let me check here. What was the first one? It was, I'm sorry if I speak your name wrongly, but it's Madhu. Is it correct? So go ahead.
Yeah, that's more or less it. Am I audible? Okay, so I really loved your presentation. I just wanted to ask a question which kind of sort of is based a little bit on India's current condition, because I'm from India, but I'll still try to make it general. Basically, in India, we are trying to, and I'm pretty sure it's true for other countries as well, we're trying to like empower traditional systems of medicine along with the existing modern medicine. So modern medicine lies on the corpses of a lot of colonial, basically a lot of colonial bodies. But that's the thing, in an effort to try to counteract this form of colonialism, which strongly exists in modern medicine, what happens sometimes is that traditional medicine kind of start opposing like some very like established facts of modern medicine, which makes it problematic, because especially during the corona pandemic, we saw that that a lot of misinformation was circulating in the system. So this is where we kind of sort of come at a like a standoff, or some kind of basically a stalemate, where we cannot decide how to engage both these systems properly in an effort to both decolonize modern medicine as well as include traditional medicine systems and include their voices. So I would like to hear your perspective on how to strike this balance, or strike this like a mutual empowerment system of sorts.
Okay, great to have you. And the question that you've raised is extremely relevant, and it covers many critical areas. You spoke about COVID, but we know that, for example, in relation to practices, gender-based practices, this is also a very challenging matter. I would say there are two things that are important here. One is knowledge translation. It is my belief, I'm 60 years old. I've been working since I was 23 in the area of health, and I lived in different countries. So one of the key issues is knowledge translation. This means the modern knowledge is poorly translated to the population. We sometimes don't understand it properly. We who are accustomed to this language, we who are accustomed to this way of expressing ourselves, because clearly there are many languages to express one phenomenon. There's not just the one language. Many times campaigns of this nature come from headquarters, WHO headquarters. Nobody knows anything about that. So you translate it once, twice, three times. I mean to say, from English into, how many languages are there in India? Many, hundreds. In Brazil, we have indigenous populations that speak, that are, I don't want to run the risk, but like a bit more than 1 million. And there are more than 100 languages among these indigenous groups. So we're talking about a diversity that exists all over the world in terms of languages, indigenous languages. But furthermore, we have to be very attentive to this question without simplifying, because there is sometimes the tendency to do that, to simplify. So in the first place, I would say there is many times resistance to this modern language, or modern medicine, or I don't know, biomedical, right? Biomedical medicine. And that creates barriers in terms of its acceptance on the part of the population. And second, the importance of mobilizing on the political level. Many countries, including India, Brazil, many countries in Europe as well, had extremely controversial positions coming from authorities and ministries of health and presidents in our case, that gave conflicting fake news messages to the population. So the population was bombarded by messages that made it even more difficult and more complex. So we have to simplify. What I'm saying is we need to simplify. Apart from the question of the language, is we need to simplify. We need to simplify and make it such that the opposition to the traditional knowledge and practices not be totally and completely dismissal. There can be how do you say, there can be a bridging between these two practices and a way not to totally throw it out and say, no, this doesn't make sense. I'm sure you don't do that. But I mean to say, not to totally dismiss it, to say, okay, that's fine. Many people, for example, resort to spiritual practices. Many of these practices do no harm, essentially, do no harm. There is no reason to refute them, and there's no reason to dismiss them totally. Even if you don't accept them as a practitioner, as an individual practitioner, you can say, okay, that's fine. That makes you feel more relaxed, because we know about that, don't we? We know that health englobes the spiritual side of things. It's not just the biological and the psychosocial. There is the spiritual as well. And religiosity enters very strongly there. So we can find ways to not antagonize and not oppose totally, and at the same time reinforce via the translation of knowledge, because I have the strong feeling, and from my experience and practices, that we still struggle. I'm saying in academia, in these circles of biomedicine, medical practices from the West, essentially, there is a problem in knowledge translation, and we have to accept that, and we have to work on it so that it's more possible for the population to make sense of it in their reality. Because many times we say things like, wash your hand with soap 5 times with each contact. Like I was saying, I exemplified with these 2 matters of social isolation. It was a joke. It was a joke. There was no way. So what do you do? Many times, I'm just going to wrap up my answer with this point. Many times, the answers lie in political terms and in social policy in specific. So in relation to COVID that you pointed out, what we did in Brazil was there was a movement, a very strong movement amongst the middle class in order to, especially the domestic help, the people, the women who effectively make our lives possible, because without them, for us as women, there's a gender also question here, and many times it's not even addressed, to ask them not to come to work and to pay their fees, during that period, because the government was not doing it, contrary to the situation in Europe. In Europe, they were doing that. They were compensating the population. So there has to be, I said social policy, but effectively this is more on the level of social mobilization in that sense, for those who have the capacity, who were able to continue with their income and so on. So effectively the health and the public health, and by extension global health, entails many things further and more than the mere practice and implementation of competencies of healthcare lines, or whatever it is, the instrument that is used within a health system. So it has always to be supported also by, and I'm going to introduce this term because maybe at some point later on I'll speak about that, which is solidarity. And solidarity is a very, very important term. And during COVID, we've seen that. We've seen that big time in terms of how Cuba sent medics to the north of Italy when nobody wanted to go. Nobody wanted to go. They asked for help from Europe and from the US. Nobody wanted to go. But we have a model, a medical model in Cuba that always helped, be it in Haiti with cholera, be it in Ebola, be it in situ, and they train on the basis of public health with solidarity as an ethical reference, not as a philanthropic, because philanthropy is good, but you need something much bigger, much more powerful in order to mobilize change. So I gave this as an example because we saw in COVID what lack of equity translated itself. The United States bought a good part of a certain medication they wanted to exploit the market. Canada bought twice the number of vaccines of its own population and would not allow. There was a competition, a totally unequal competition. Israel was donating, giving vaccines to countries in exchange for voting in the United Nations, contrary to Palestinian rights. So we saw scenarios, political scenarios, in a question, in a pandemic, that is purely humanitarian, that is purely, reflective of how vicious the powerful countries were able to exploit and get back returns in terms of a tragedy like the COVID-19. I hope I gave you some feedback to your question.
That answers my question. Thank you so much.
Thanks so much for the question and also for Dr. Muna's answer. So we're a little bit ahead of time. And Luisa also shared here in the chat box the attendance form. So please answer the attendance form. We're going to go to the next 2 questions. And if that's not a problem for Dr. Muna, can we set a time to answer in the question? Is that all right for you? Because I'm a lot afraid that we might pass through time. And
okay.
So is that good for you? 3 minutes? Is that good? Okay, perfect. Yay. Okay. So Leon is the next one. So please, Leon, open your mic and go ahead.
Hi, Dr. Muna. Thank you so much for your presentation. And sorry that my camera's not on. I have very bad service. My question is the following. So we see that throughout colonial times, a lot of tropical research institutes were initiated, initially with a colonial interest, but throughout the past decades and centuries, they've led to a lot of very important medical advances. So my question would be, how do we bring in concepts of decolonization while at the same time making use and making the most of the medical advances that came as a result of this? Thank you.
That's an excellent question. You are from where? Can you identify, please?
I'm German American, so I grew up in the States, in New York, but I study in the Netherlands now.
Excellent, excellent. Thank you very much, because I was aware of the origin of the speaker before you, so that's why. It's an excellent question, and it's very, very valid. We do want a universal science. We do want, this is what one would aspire to, equity, and that would bring returns for everybody. We know that there are obstacles. Many of these responses, answers to diseases and health problems did not bring the expected return for many lower and middle income countries. They are very expensive, prohibitively expensive. We know about the pharmaceutical industry and the way that it operates. And we know that it makes it such that even generic alternatives are debated. When Brazil in the 90s had a serious problem with HIV and contested the pharmaceutical companies with generic brands, they were taken to the courts, the international courts. And Brazil said, I don't care. I really don't care, because I have such a critical situation. And this was humanitarian, on purely humanitarian basis. So the question is always, to whose benefit? And why are the alternatives rejected by big powers? And by big powers, we mean the deep state, if you like, I don't know. I mean to say, it's not the pronouncements of one country through its president or whatever, but it's the manifestation of that through the conglomerates or the multinational companies, and especially the big pharma, what is called in literature. So these are huge powers. So we need to work on this front to decolonize, and it's a tough one. It's a really tough one.
Thank you very much.
Oh, amazing. Very
I tried to stick. Yeah. I know you gave me you called my attention. I'm aware of this. Yes, please.
Okay, so we have one more question from Violetta. She said, is in the chat box. So thank you so much for your amazing lecture. Do you have any advice in convincing our medical schools and also teaching the decolonization of global health? Often they just ignore our remarks. So I was wondering whether you have some tips for us with all your experience.
That's another excellent question. Yes, you have to keep pressing. You have to put pressure And I know in Brazil, the students make a huge difference. They protest, they go out on the streets. When they don't like something, I'll give you an example, and it has to do with colonization. Some time ago, Brazil is a very unequal society, as many others, but we specifically speak about two groups, the Afro-Brazilians, the Black population, and the indigenous, who have historically been deprived of entry into universities, and specifically in health sciences, medicine and health sciences. And so we've been struggling with this for the last decade and a half, almost now, and we have affirmative action policy, which is having a fantastic effect, but still we need much more than that. And then during a class, one student from my university, but this happened 2 or 3 times, the professor said, a medical professor said, yeah, okay, I explained now the class, and now I'm going to explain it in simplistic terms for the indigenous students to understand. And he said it jokingly. So the students went out on the street. They demonstrated in the corridors, and they said, oh, we are not going to take classes. You know, there is a strong, how do you say, student movement, and they, although there is opposition. So, for example, they did all of this, and the heads, the consortium, right, of the professors at the university didn't want to do anything because they wanted to stand together with the professor and said, no, he was joking, it's not serious. They insisted. And with their insistence and persistence, he had to apologize. And effectively, also, they wanted that this be publicized. He had to apologize and say that he will not do it again or whatever. In other terms, they could have processed him, could have taken him, you know, to a procedural kind of thing in order to make sure that this kind of attitude that is so highly destructive, very, very destructive, so much so for the group of indigenous students as well as for those who are not indigenous. So I think by persistence, you will get there. I see the influence. I mean, the things that you say and that you put in the page are things that we rarely have discussed in the construction of the curricula. So I'm always inspired by students, and I believe very much in your power. So you have to be persistent, and you have to repeatedly keep speaking about this. I'll give an example and then I'll conclude. I have 2 classes, one in postgraduate level and one in the graduate level, on collective health or public health, collective health and mental health. And I leave my bibliography open. You could propose this to your professors, for example. So I leave my bibliography. In the first class, I say to students, if anybody has a reference to add, please do that. We'll look into it and we bring it forth. And this is important because it means that the bibliography, which is an important reference, it's what molds your mind, what's going to make you, you know, what questions are important, what is critical. And so this bibliography grows from time to time by the students proposing things and suggesting. And so you have to persist and you have to insist and you have to be very bold and not give up. And also the way that you're doing, you know, by making consortia of students from all over the world, put pressure more and more on the curricula. The curricula has to change. Professors will rarely change it on their own. It's you.
Thank you so much, Muna, for your answer. And I saw that, I don't know if I'm speaking your name correctly, but Inesh raised his hand, but I'm not sure.
I did. It's Inesh. Thanks. I am not too sure if it's relevant to the topic, but I just had a question for you, ma'am. Can I ask you, if possible?
Yes, sure.
So, as you know that the situation in Ukraine and how medical students from India who were studying there were forced to go back to their countries back in India. So let's say he was an undergraduate student studying in the 3rd or the 4th year of medical school. and he comes to India. So right now I'm not that updated with how the jargon has been with respect to how the government is, placing them into medical colleges. But in an ideal situation, what according to you would be the strategic plan, so that, because the medical colleges are filled, let's say a class of 150 students, it will have 150 students. So what these students were migrated from Ukraine to India, or let's say to respective countries, what do you think would be an ethical approach, so that, with respect to medical education, they can be put into colleges which are already filled, because their education is at stake right now? So that's my question.
This is, wow, what a difficult situation. Is that yours? Is this your situation, Inash?
I've read about the news, because
Okay.
we have Indian medical students in Ukraine who, of course, came back to India because of the situation.
Yeah.
But I think generally many other medical students across different countries who are there in Ukraine and forced to go back to their home countries.
Yeah.
So how is so the education approach towards them?
Yeah.
That's what it was.
Yeah, I mean, this disruption is terrible, must be terrible on the individual level and on the collective. One thing I think is that the universities should be flexible. They should be flexible, and they should diversify the way, because I understand that there are resources in terms of training, placements in the hospitals where you do the training and all of that. But I think there should be flexibilization. I very much like the model of night classes. I don't know if you have that in India. We have this here in Brazil. And this alleviates a little bit. So there are students who work. My course, for example, is a nighttime class, course. So because it comes originally, most of the students are, in the labor market. They're young, but they have a difficult economic situation. And then, so they work during the day and they study at night. And all the time we have to make flexible propositions and ideas. Another one is to do hybrid education where possible, right? So in order to alleviate the pressure. So the university would have to look, in India in this case, to look into possibilities of diversifying, hybrid online education and presential or in person. This is another idea that comes to my mind, but certainly, this means, how do you say, a lot of work, I would say, as someone who works in administrative questions regarding training and university. So this needs goodwill. And finally, and I'm always instigating you guys to confront and do all sorts of demands, putting your demands there. I think the student groups have power, and they can, when they unite together and create platforms that are of different regions and locations, put pressure on this. But it has to be through flexibilization. And so I spoke about the nighttime option of training, and the other one is online, to do a hybrid kind of thing, mixed. I hope I gave you some insight to this.
That's a really good suggestion. Thank you so much, ma'am.
You're welcome.
So yes, so I think that this is basically the whole general part of the Global Health Studies group. So thank you all for your questions, and thank you so much, Dr. Muna, for being here and to give the first lecture ever in this study group. So thank you so much. To conclude our day today, I will ask you, if that's possible, to open your cameras, to take a picture, to take a final picture with all of you, because we have people from all around the world, and we have to have this record as a picture. So please, if you can, open your camera. If you don't feel comfortable, you don't have to open your camera, or if it's not possible to open your camera, we also understand. So I will give you 30 seconds, and I have a chronometer here, so I will call 30 seconds so everyone can open your camera. And I will also ask Louisa, is that possible for you to take the picture? Okay, perfect. So yes, count down on the screen, guys. You have a few seconds to open your cameras. Oh, I see so many faces. Oh, that's so beautiful. Okay. We have like 10 seconds left if you want to open your camera. Okay. 5, 4, 3, 2, 1. Okay, Luisa, can you do the countdown to the picture, please?
Yes. So I'll count on 3. So 3, 2, 1. Smile. Okay. I took
Okay.
it.
Yay, perfect. Thank you so much, guys. Please remember to fill the attendance form. Luisa, can you send that again here, please, in the chat box? So please fill the attendance form. And remember what Luisa said in the beginning, to have the certificate, you have to be here and fulfill the attendance form 4 to 8 times. So please do that. And again, thank you so much, Dr. Muna. It was amazing. Your lecture was amazing.
Thank you.
As
Thank
you
you.
know,
Can you
like,
please
you
make it
love it so much.
available? I'm sorry. Can you make it available? It's it's for anybody to consult. It's fine by me. Okay.
Okay. Thank you, Dr. Mona. Was amazing. I really
Thank you
loved
for
it.
the invitation. So I'm leaving. Bye-bye. All the best to you guys. Very
Bye.
good. Bye. Bye.
Thank you, everyone. Thank you for joining us today. And I see you on the next meeting. I will see your comments about how we can improve, and the next meeting will be better than this one, and we will improving each day. So thank you, everyone. Bye-bye. See you.
Thank you. Bye-bye.
Bye.
Thank you. Bye.
Bye.
Thanks, guys. Bye-bye.